Our group going to present infective endocarditis. My groupmates are Francisco Catime, Gilarte Eric, Marasigan Walter, Miranda Aris, and yours truly, Hoxon Erica Jean, under the supervision of our clinical instructor, Dr. Red Lico. For our introduction, according to American Heart Association, infective endocarditis, also called bacterial endocarditis, it is an infection caused by bacteria that enter the bloodstream and settle in the heart lining, a heart valve, or a blood vessel. IE is uncommon, but people with some heart condition have a greater risk of developing it. Infection can result from many sources, including poor dental hygiene, toothbrushing that causes minor injury to the lining of the mouth or gums, dental procedures, implanted cardiovascular medical devices, chronic skin disorders and infections, burns, and infectious diseases.
Overview of the case. Patient JF is a 50-year-old married homemaker with a genetic autoimmune deficiency. And the diagnosis, infective endocarditis, is the most recent episode where a Staphylococcus aureus infection of the mitral valve 16 months ago and a Streptococcus viridans infection of the aortic valve 1 month ago. For the history, coronary artery disease for several years and 2 years ago suffered an acute anterior wall myocardial infarction and a chronic joint pain, and 2 years ago 18-month course of parenteral nutrition for malnutrition caused by idiopathic, relentless nausea and vomiting. And now for the admission assessment, we have the vital signs of a blood pressure of 152/48 in supine position and 100/40 in sitting position, a pulse rate of 116 beats per minute, respiratory rate of 22 breaths per minute, and a temperature of 37.9 degrees Celsius. For the objective data, oriented times 3 but drowsy, grade 2/6 of holystolic murmur, and a grade 3/6 diastolic murmur noted on auscultation. Abdomen is soft with slight left upper quadrant tenderness and a multiple petechiae on skin of arms, legs, and chest, and splinter hemorrhages under the fingernails. Hematuria noted in voided urine. And now, the summary of significant findings. The echocardiogram showed moderate aortic stenosis, moderate aortic insufficiency, chronic valvular vegetations, and a moderate left atrial enlargement. And the laboratory results showed a BUN of 85 mg per deciliter, creatinine of 3.9 mg per deciliter, a glucose of 165 mg per deciliter, hematocrit 27%, and a hemoglobin of 9.0 grams per deciliter.
This is our pathophysiology. Legend shows three important colors. Red indicates disease, green indicates manifestation by patient, and yellow for disease occurrence. Under our risk factor, non-modifiable includes patient 50-year-old female married, and for modifiable factor include health history of autoimmune disease, wearing of dental bridge, Staphylococcus aureus in mitral valve 16 months ago, and Staphylococcus viridans in aortic valve 1 month ago, as well as presence of PN site since patient is under parenteral nutrition. It's quite challenging for us to connect three diseases altogether. However, we should know that myocardial infarction, specifically acute anterior wall, happens to be part of the health history of the patient. Infective endocarditis, which is the existing condition of the patient upon admission, and renal failure, which happens to be the complication of the underlying disease. So first, I would like to discuss the occurrence of myocardial infarction. It is usually caused by coronary atherosclerosis, which begins as fatty acids, lipids that are deposited in the intima of arterial wall. Once untreated, this causes smooth muscle within the vessels to proliferate and form atheromas or plaques, which finally results to obstruction in the arterial wall. This will decrease the blood flow, which directly affect the cardiac functions. It is evident because in the case of our patient, the echocardiogram reveals moderate aortic stenosis, moderate aortic insufficiency, and presence of heart murmurs. Whereas pulse rate is 116 beats per minute, RR is 22 breaths per minute, BP while supine is 158/24 and 100/40 upon sitting. The continuous development of atherosclerosis involves an inflammatory response. The area of infarction in the myocardial tissue takes time to develop. As the cells are deprived of oxygen, ischemia develops, and cellular injury occurs, as well as the death of the cell necrosis, and finally, the myocardial infarction. Next disease, which is the underlying present condition of the patient, is the infective endocarditis. Due to the effect of myocardial infarction, there is high incidence of hadrons of bacteria, as I've mentioned Staphylococcus aureus and Staphylococcus viridans, which is the common causative agent associated with this disease. They will enter into the bloodstream and the turbulence of blood flow damage endocardial lining. As parts of inflammatory response, there will be a release of cytosine in the bloodstream, and it might result to fever, which is evident due to the temperature of 37.9 degrees Celsius of the patient. She is also experiencing nausea and vomiting, chills, fatigue, joint pain, as well as headache. Then the infection of thrombus leads to vegetation, which bacteria forms a colony. Vegetation can be seen in the echocardiogram. Like for instance, the echocardiogram of the patient reveals chronic valvular vegetations. The infections of thrombus will affect the viscosity of the blood since the patient's hematocrit is 27% and the hemoglobin is 9 gram per deciliter. Inflammation, once untreated, is the cause of infective endocarditis. Then finally, the last disease, which is the renal failure, which is caused by the presence of vegetation. Due to bacteremia, this will directly detected by the immune reflexes deposit in the kidney, which will result to damage of glomeruli. All the blood passes to the glomeruli will be filtered by the nephrons, and as for the results of BUN or blood urea nitrogen and creatinine of the patient, it shows some abnormality since the BUN is 85 mg per deciliter and for creatinine is 3.9 mg per deciliter, which clearly indicates the renal failure.
For our concept map, we come up with 4 prioritizations. Priority number 1, ineffective tissue perfusion related to coronary artery spasm as evidenced by chronic valvular vegetations. Priority number 2, risk for decreased cardiac output related to coronary artery spasm as evidenced by presence of heart murmurs. Priority number 3, risk for deficient fluid volume related to compromised regulatory mechanism as evidenced by decreased hemoglobin and hematocrit. Priority number 4, risk for fall related to orthostatic hypotension as evidenced by nausea, headache, and fatigue. For our priority number 1, this is our assessment for our nursing diagnosis, ineffective tissue perfusion related to coronary artery spasm as evidenced by chronic valvular vegetations. Planning, after 8 hours of rendering nursing interventions, patient will be able to identify factors that improve circulations, patient maintains maximum tissue perfusion to vital organs as evidenced by normal peripheral pulses and vital signs within normal range. Interventions, independent, monitor vital signs to establish baseline, assist in changing position every hour, instructed to avoid leg crossing, teach factors that improves venous blood flow such as restriction of putting pillows behind the knees, check for optimal fluid balance, monitor urine output. Dependent, administer medication prescribed by doctors such as furosemide lasix, amlodipine norvasc, potassium chloride Cadar, and metoprolol Lopresor. Maintain oxygenation as prescribed by the doctor. Submit patient to diagnostic tests as indicated. Collaborative, refer to dietitian for balanced sodium intake. Evaluation, after 8 hours of successful nursing interventions, patient verbalize understanding of factors that promote venous blood flow, vital signs within normal range, BP 120/80, RR 18, PR 80, temperature 36.5. For our priority number 2, this is our assessment. For our nursing diagnosis, risk for decreased cardiac output related to coronary artery spasm as evidenced by presence of heart murmurs. Planning, after 8 hours of rendering nursing interventions, patient will be able to demonstrate adequate cardiac output as evidenced by blood pressure and pulse rate and rhythm within normal parameters for patient, strong peripheral pulses, and an ability to tolerate activity without symptoms of dyspnea, syncope, or chest pain. Interventions independent, monitor vital signs for baseline, closely monitor for symptoms of heart failure and decreased cardiac output, including diminished quality of peripheral pulses, cold and clammy skin and extremities, increased respiratory rate, presence of paroxysmal nocturnal dyspnea or orthopnea, increased heart rate, neck, vein distension, decreased level of consciousness, and presence of edema. Dependent, administer medications prescribed by doctors such as furosemide, Lasix, amlodipine, Norvasc, potassium chloride, Kedar, and metoprolol. Evaluation, after 8 hours of successful nursing interventions, patient demonstrate adequate cardiac output, vital signs within normal range, BP 120/80, RR 18, PR 80, temperature 36.5. For our priority number 3, this is our assessment. For our nursing diagnosis, risk for deficient fluid volume related to compromised regulatory mechanism as evidenced by decreased hemoglobin and hematocrit. For our planning, after continuous nursing intervention, the patients will be able to maintain an appropriate urinary output. For our interventions, independent, monitor intake and output, noting to include hidden fluids such as IV antibiotics, additives, liquid medications less than 2 liters per day. Consider the result of GFR. Monitor urine specific gravity, weight daily at same time of day on same scale with same equipment and clothing. Monitor diagnostic studies, blood urea, nitrogen, creatinine, hemoglobin, and hematocrit. Dependent, encourage patients to take furosemide as prescribed by the doctors. For the evaluation, after performing the nursing interventions, the patients maintain an appropriate urinary output. For our priority 4, this is our assessment. For our nursing diagnosis, risk for fall related to orthostatic hypotension as evidenced by nausea, headache, and fatigue. Planning, after 8 hours of rendering nursing care, the client will be able to verbalize knowledge about the reason of present health problem, verbalize knowledge about ways to treat the health problem, will express agreement in the treat regimen, establish reduced risk of injury and any other accident, establish comfort in using assistive devices. After a month, the client will establish signs of safe well-being and reduce risk of accidents. Intervention, identify onset and trigger for the symptoms, relieving or aggravating factors, symptoms pattern, associated symptoms, and history of similar episodes. Check vital signs, especially postural BP, presence of an irregular heart rate or fever. Assess cardiac rhythm and rate. Assess for use of eyeglass or hearing aids. Maintain patient safety. Encourage the patient to wear waist-high compression stocking. Provide a safe environment by moving side rails up. Encourage the patient to get up slowly. Educate older adults to change position slowly to compensate for age-related changes in vascularity. Encourage the patient to use semi-Fowler or Fowler's position. Administer medication for dizziness as ordered. Instruct patient and families about purpose, action, and effects of ordered medications. Encourage the use of assistive devices for safety until the condition resolves. For evaluation, goal was met. After months, the client verbalized knowledge about the recent health problem and verbalized knowledge and self-care management if the symptoms appear. And the client also purchased a healthy and safe well-being with the use of assistive devices.
For the medications, penicillin used to treat bacterial infection 2 million units IV piggyback every 4 hours. Furosemide used to treat high blood pressure helps your body get rid of extra water and salt 80 mg orally once a day. Amlodipine lowers your blood pressure and makes it easier for your heart to pump blood around the body 5 mg orally once a day. Potassium chloride, used to prevent or to treat low blood levels of potassium, helps the kidneys to filter blood 40 ml equivalent orally once a day. Metoprolol, used to treat high blood pressure, it lowers heart rate 20 mg orally 3 times a day. Chlorperazine, used for the treatment of severe nausea and vomiting, 5 mg IV push as needed. For the discharge plan, environment or exercise, advise the patient to avoid heavy housework. Participate in a regular daily program of activities that do not produce chest discomfort and shortness of breath. Avoid exercises requiring sudden bursts of activity. Alternate activity with periods of rest. Avoid physical exercise immediately after a meal. For the treatment, instruct the patient to take only medicine prescribed by the physician. Encourage the family to create a medication plan list to avoid medication error. For the health teaching, advise the family to watch out for the signs and symptoms of myocardial infarction and endocarditis, which includes changes in chest pain or shortness of breath, cold sweats, severe abdominal pain, bloody urine, and fainting. Advise the family to avoid dental procedure for 6 months and skin infection as necessary. For the outpatient, advise the family to post a schedule to follow up check-up for the laboratory test of hematocrit and hemoglobin. For the diet, follow the formula for parenteral nutrition as prescribed by the doctor. Eat a diet low in saturated fat, high in fiber, and if indicated, lower in calories. Advise the family about parenteral nutrition administration. Instruct the family to clean the parenteral tube every 3 days to avoid contamination.
For our recommendation, as part of health promotion, we would like to recommend to monitor the patient's weight, intake and outputs, peripheral edema, and any signs of heart failure. The patient can also be placed on low-sodium diet and maybe even follow a renal diet. I would educate them on the proper way to clean the dentures, gums, and rinsing of the mouth after brushing. For our conclusion, patient is a 50-year-old with a genetic autoimmune deficiency and suffered from recurrent infective endocarditis. The patient has been readmitted with endocarditis, nausea and vomiting, and renal failure. Endocarditis is an infection of the endocardium, which is the inner lining of your heart chambers and heart valves. Kidney failure occurs when your kidneys lose the ability to sufficiently filter waste from your blood.